existing evidence and known lack of evidence, making evidence maps and developing and generating them, methodological issues by distinct type of intervention and by type of population. I think that we have a pretty long track record of evidence-based medicine by now. And we realize, even before the advent of the pandemic, that for most medical interventions, and that includes public health interventions, we have either very limited or no evidence, or we have evidence that is of questionable quality, of questionable validity, not necessarily convincing enough sometimes, even when there is a substantial amount of data. So it's very important for any topic to make sure that we start by mapping out what exactly we have learned, what kind of data we have. And there's a whole factory of systematic reviews and meta-analysis that has evolved with an accelerated pace over the last couple of decades in particular. These systematic reviews and meta-analysis, they have a pretty standardized methodology, but nevertheless, we see that many of those that are published in the literature, they are falling short of the standards that we would expect. So it's not only the primary data that are lacking or are of less than optimal standards, it's also the evidence maps that we generate from systematic reviews and meta-analysis that often fall short of the standards that we know that we should be applying, but apparently we're not. Acknowledging these caveats, we do have maps of available evidence for most, if not all, topics at the moment. There has been a lot of interest, and many scientists have really spent a lot of time and effort and have published tens of thousands of papers of systematic reviews, meta-analysis, and evidence synthesis. And this includes also interventions related to public health. So we have tons about pharmacological interventions and medical care, and we also have systematic reviews of other more complex types of interventions. Now, when it comes to social interventions, especially the ones that are applied in the setting of a pandemic like COVID-19 in the current circumstances, the evidence probably is even more thin compared to most topics that relate to drugs or traditional medical interventions. If we limit to randomized controlled trials, there is hardly any randomized trials of social distancing interventions in the pandemic setting. Recently, I published a paper in epidemiology and psychiatric sciences with Ioannidis and Florian Naudet, looking at making a plea for having more evidence from randomized trials on these types of interventions. However, if you look at what has been available to date, there's one trial that has been done looking at whether gyms can open or not, and looking at infections in gyms that opened. There's a couple more trials that are a bit more on the periphery, like, for example, one done in India that looked at having a Nobel Prize laureate making messages to the population and seeing whether that works more than just having the regular government kind of messages, and seeing some improvement in adoption of different behaviors that hopefully are beneficial. And another trial in Botswana that tried to see whether in the setting of having closed schools, different types of messaging by phone could help the educational experience of the children that were not going to school physically. But this is pretty much it. There have been a couple of attempted trials, but which have not really happened, unfortunately. There was a trial on school closure reopening in Norway that got close to be launched, but then kind of equipoise feeling was lost. So we have very little evidence on interventions that are used in large scale across entire populations, entire countries, much of the world in the setting of a pandemic like COVID-19. And this is really concerning. The evidence gap is replaced by other types of data, lots of modeling data, and some observational data. And without wishing to dismiss this type of information, we have to be very cautious because they do have lots of limitations. Modeling is lots of fancy attempts, and I enjoy it myself, but it's unfortunately making, by default, a lot of assumptions, and these assumptions may or may not hold true, and therefore you just don't know much of the time whether the inferences of these models are trustworthy. In fact, we have seen even within the first several months of the pandemic that the vast majority of the modeling that has been done has not really been able to get realistic predictions and inferences. And some of the modeling has led even to very misleading inferences because people trust too much these predictions and they act based on them as if they were very strong evidence, where actually they're very weak evidence. Now, some models also use more data than others. Some are more data-driven and less assumption-driven, but even those that are more data-driven, these data are observational. They occur in a very unstable environment of an evolving epidemic wave. They should be seen with a lot of caution and not easily extrapolated. We have data from some other pandemics, including the 1918 influenza pandemic, and some of the original gut reactions in the case of COVID-19 were based on seeing what had happened with observational data in 1918. So, much of the flatten the curve push was based on some observational data from 1918, but 1918 was a completely different virus with very different features, very much higher lethality. And again, these data were observational, selectively collected, selectively reported, selectively analyzed. So I don't know how much one could trust those. As you realize, if our evidence is so limited and so poor and so questionable for the overall population, it's even worse when it comes to strata of demographics and social or socioeconomic strata. There's, again, lots of pieces of observations that are floating around. We know that a pandemic like COVID-19 is a disease of inequality, and it also causes inequality. It hits very hard people who are disadvantaged, people who are marginalized, people who are very weak and vulnerable for various reasons, based on age and frailty, for example, in nursing homes, but also based on social disadvantage, poverty, homeless, people in prisons, immigrants, people who cannot really protect themselves. So we know that evidence exists about COVID-19 being a major issue for these types of special populations, but we know far less about what to do to protect these people and how would we most effectively protect them. I think that in a way, at least so far, during the first wave, we have been unable to protect them. And in many cases, in many countries, many of these disadvantaged, vulnerable populations were hit even more hard than those that probably had very low risk. People like me, I'm wealthy and healthy, and I can shelter at my home and work from home and do everything I want, but lots of disadvantaged people cannot really have that luxury. They need to be out there in the street. Maybe they have no home, or if they have home, they're essential workers. They need to be continuously exposed to risk. So clearly, realizing that we don't have good evidence is the first step. And it takes some brave people and some brave statements to really push that point that we don't have evidence. You need to convince others who say, I don't care, I just need to do something because we have a serious situation here, and forget about evidence. I'm just going to act. But obviously, this can work for a very acute situation that is an acute disaster, but for a condition that is likely to last for months and years, saying that we will just follow our gut feeling and these modeling and observational data as they come, I think is a recipe for disaster. And I think that we have a very high risk of doing a lot of harm unless we just say we don't have evidence. Let's get evidence that is trustworthy as quickly as possible.
John, I highlight 3 things you said. It's not an invitation to carry on, just highlight the issue of density, quality of evidence, and how persuasive it is, which may go together or not. Mm-hmm. The second is the worse off, the less data we have.
Yeah.
A robust correlation. And the third one you hinted is it's going to be interesting to do the epidemiological forensic of all that, which will be a worldwide retrospective study with all biases, fights, and follies.
Yes, lots of follies. I'm sure that we will find lots of follies and lots of dead bodies of poor science in the process.
Not dead bodies of epidemiologists, but
yes. Well, poor epidemiologists, I don't want them to die, but I think that indeed we have seen tons of horrible papers. There's probably about 100,000 papers on COVID already published. Yeah. And it's a very tiny share of them that are really useful and are really contributing something that can make a difference in a positive way. So I'm moving to the second point.
A, B, and C go more or less together. Move to the block B.
Yes. So are you still recording?
Yeah, yes.
Okay. So sharing the evidence, making it available and actionable for professionals dealing with different media agents, both journalists and networks, and dealing with the politics and political divide and lobbying. So in principle, sharing evidence sounds like a no-brainer. Complete sharing sounds like the best strategy. Science should be open. It should be communicated. It should be shared with the entire scientific community. We should not hide anything under the carpet. We should try to be open and transparent and engage with other scientists in cross-sharing the evidence that we get, because otherwise we end up in situations that we have witnessed again and again of the available evidence being just a subset of the evidence that has been generated, that subset being distorted, being biased, creating erroneous estimates of treatment effects, of various estimators of interest, and eventually when we act based on wrong information, selected biased information, we can cause harm rather than benefit. So this is easy to say, it's more difficult to do. Unfortunately, a lot of evidence is not shared for various reasons. There's a huge literature on publication bias, on selective reporting, on why that happens, on the incentives for sharing data that sometimes are focusing more on sharing extravagant, extreme, significant results and lots of more modest, moderate results, non-significant results do not get to be disseminated. Sometimes there's conflicts of interest. In the case of a pandemic, you have like a complete mess of very fast moving science, peer review being subverted, probably by zealots sometimes who want to accept papers that fit their worldview immediately and not accept or destroy papers that are proving that their thoughts and ideas and ideologies are wrong. So these biases that exist, and we have very well documented them along many, many decades across biomedicine and other scientific fields, when it comes to the urgent setting of a pandemic, I think that they can really get worse. So I think we need to struggle to see more sharing and more even sharing of information. Now, there are some tools that are helping such sharing. For example, in the last year, we have seen a dramatic increase in the use of preprint servers, and a very large number of papers are submitted to preprint servers before being peer-reviewed. I think this is good in principle. I have been one of the supporters of preprint servers. They have worked very nicely in the physical sciences for over 20 years now, and I think it's about time that we see them used also in biomedicine in large extent. The problem with this is that in a very tense, politicized, polarized environment, you will get media and social media being involved in critiquing, assessing, smearing, distorting some of that science. And I've seen that very intensely in the COVID-19 situation. In COVID-19, media and even more social media really took control of science to a large extent. And that's very unfortunate because these are people who are not trained most of the time to really cover science. We've seen a deficit of science journalism even in the past. There were very few journalists who knew about science. Also, many scientists, in a way, became media agents during the pandemic. I know of many highly respectable colleagues who became social media animals. Social media are not necessarily a place to have balanced scientific discussion. They have the benefit of rapidity and of some sort of unhindered expression, which is great. But at the same time, it creates a situation where science is shaped and approved or disapproved by large mobs rather than careful thinking, proofs, evidence. You have people who can tweet away more than their opponents, who can harness a larger crowd of followers, and also journalists who can really shape a given reality of evidence, which may have very little to do sometimes with real evidence.
That was point E, your letter to the BMJ on clickbait and manifestos.
Yes.
But carry on, please.
Yes, that editorial I wrote to express my concern about using machineries that are not part of scientific method, but part of activism and advocacy to replace the scientific method. I've seen many scientists who somehow in their tweets and in their open letters, in their social engagement, they say, many scientists agree with me, and my opponents, they're just fringe people. They belong to, they're pseudoscientists, even worse. And pseudoscientists may include Nobel laureates and extremely talented scientists and some of the top methodologists in the world. So it creates a very explosive mix when you get scientists behaving as activists or advocates. And collecting signatures is probably one such example. I'm perfectly fine with collections of signatures when it comes to ethical issues like people being fired or some ethical issue in the community that needs to be settled with mobilization of opinion. But saying that I have one scientific theory that I will prove it because I have collected enough signatures. This is completely ridiculous. I think that Copernicus would have collected one signature and he would have had probably thousands of quote-unquote scientists in his era saying that his heliocentric model was entirely wrong. Einstein in 1905, again, he would have a single vote for his new theories, and if you were to ask everyone else, they would say they hadn't heard about it, or that would be completely wrong, and they would be wrong. The third point is the involvement of politics, which makes things even worse. I have felt that science has had kind of a difficult relationship to politics. Ideally, you want science to inform society and leadership in making decisions. This is the ideal situation when good science based on good evidence is informing the decisions of our society. And obviously these decisions will be made in most circumstances by politicians or other types of leaders. However, you reach the situation where you may see that politics is subverting science, that politics is taking control of science in different ways. And what we have seen in the COVID-19 setting, we have seen that scientific positions were espoused by specific entities in the political divide. If you were to claim that you believe in X, you would be immediately classified as conservative or progressive or Trump supporter or Biden supporter. And again, I think this is completely ridiculous because science is not dictated by politicians, by parties, should not be an issue of political divide. We all struggle to find the truth, to come as close to the truth as possible, to minimize error, to minimize bias, to get rid of existing biases. First of all, we need to detect them. So having that whole political turmoil superimposed on science really creates a very difficult situation. And obviously then you get all the methods of politics, including lobbying, including subversion, including smearing of opponents, including fake news, including social media campaigns, including distorted journalism that are infused into science. And that can be devastating. I think science is very delicate. If you start treating it with such doses of poisons of that sort, science is dying. And what you're left with is just angry, opinionated experts at each other's throat, which is not what science should be at any point by any means. So should we move to point C?
Please.
Compliance. How far and deep could be its assessment robust, evidence-based? Individual medical care, including individual prevention, individual behavior modification, for example, lifestyles change. More specifically, how to improve citizen compliance on preventive measures among the healthy, especially in front of pandemic alert, voluntary restraints versus mandatory or enforced restraints. Ideally, how small should be legal enforcement and policing? I think that the literature on compliance with different interventions is not that extensive. There are systematic reviews and meta-analysis, and there is a literature on adherence and on compliance. Most of it is about medications and treatments that are prescribed. There is some literature also on behavior modification and lifestyles change. We know that this is difficult. If I were to summarize that literature, I would say that lifestyle is important, but it's not easy to change. And even when we do have some success with some interventions, we do have a problem with maintenance. At least this is what several decades of trials and other studies have suggested for lifestyle, like diet or exercise. There's quite some literature on smoking cessation, which has proven to be very difficult. It's not that we don't have success stories. We have success stories, but there's always a wish to have more than what we have achieved. For diet and weight loss, we see that most diets don't really seem to have any substantial difference from each other. Maybe some could achieve a little bit better impact early on, but most people really regress back to previous condition. So I think that the issues of acute versus chronically maintained behavior is important. When you come to situations of pandemics where you use lots of measures, as I said, with very little or no evidence support, but based on gut feeling and some kind of tenuous data, I think that compliance in the short term probably is mostly dictated by fear. So I think that we do see that in most countries where mobility data had been collected, regardless of what interventions were proposed by the governments or local authorities, people did decrease their mobility. They decreased their exposures as soon as they started seeing that and hearing in the news that there is a lethal pandemic and people are dying in hordes and it is coming your way. People on their own, mostly, regardless of measures, they stopped exposing themselves. They just stayed at home. They stopped going to work. They stopped going to bars and restaurants and theaters and even doing things like walking outside of their homes.
I don't know in Greece, but in Spain, Italy, France, there was something called the balcony vigilante. So neighbors shame neighbors not behaving.
Yes, yeah.
That was an active participation. I was applauding the healthcare people, but the same way it appeared, it disappeared.
Exactly.
It was for a while.
So you have that social pressure, especially in the acute setting. However, I think that what the data have suggested is that this type of behavior is not something that can be maintained for a long time, especially when it leads to devastating consequences for people's livelihood and their mental health and other health issues and the economy and society at large. There's fatigue. And for a pandemic where people may be afraid not just for a couple of weeks, but for several years, I'm really worried that it's not really easy to insist on measures that would be very hard on daily life and daily activities. I mean, creating a situation where people stop living with the prospects that they may live again in who knows when, in 2 years, in 3 years, 4 years. I think that people start realizing very quickly that that sounds very weird. I'm doing this to live and I'm not living. So we have very little evidence that mandatory or enforced restraints are doing any good. So especially in the setting of ensuing fatigue, I don't have evidence for that, but I can bet that it's more likely that they will do more harm than good. I think that they will create even more fatigue. I think that they will probably damage even more mental health and other adverse consequences of that whole setting. I think that these are things that we need to study, because otherwise we end up in a situation where many governments and leaders are kind of announcing new measures every week, if not every day, and just following some non-reliable indicators like number of cases, which of course depend on how many people you test. And whenever they see a spike or an increase, they feel pressured to impose even more measures, as if that would do anything, although we have no evidence that all these minute variants of aggressive or more aggressive measures really would be helpful. So I think that in principle, I'm not in favor of legal enforcement and policing. I think that I'm willing to get pushback on this, and I would like to see pushback generated with some reliable evidence. And ideally that could include randomized trials, as we discussed at the very beginning. But I'm worried that the balance of benefits and harms, we know so much about the potential harms in terms of absolute magnitude, even though they may not be accurate. If we're talking about 50% of the population becoming infested with anxiety or depression, and 25% of young people having suicidal ideation,
yeah.
Even if this is like 50% off and our estimates are not accurate, you would need a tremendous benefit of these legal enforcements to even match this, let alone all the other adverse consequences. So off the start, I think that these aggressive legal enforcements seem very problematic to me. Point D.
Additionally,
Yes.
The style of transmitting the enforcement can be insulting. It can be challenging to your own, not narcissism. If you are a high school graduate, they should treat you as a high school graduate, so to speak.
Yes.
Not as an asshole. Not a potential delinquent asshole, which often is the tone.
I think that many people do feel insulted. They feel that their freedom is restrained, that their very fundamental rights are restrained. What would a dictatorship do more? I don't think that any dictatorship has managed to really restrain life as much as some of the lockdowns have, by a large margin of difference. So I'm not a conspirator theorist or anything, but I think that people who apply these measures are well-intentioned, but I don't think that they consider the horrible perception that many people get out of these measures. Now, there's other people who might feel that not taking measures is a sign of weakness of their leaders. So one needs to balance these two perspectives. People who say, please shut down everything, we're dying, and you have the counter argument here that some of these leaderships feel that they need to respond to that quest for maximal measures. But I think that this is getting to the point of some sort of psychopathology, and we know that even under normal circumstances, a very large share of the population has phobias for pathogens. In the current setting, where we have a virus that has been trumpeted wide and right and left as the major pandemic of the century, these phobias become very dominant in the population, and I think that they can be devastating. So we need to navigate very carefully these waters, but obviously there's a lot at stake. Moving to point D. Yeah.
Do you want to have a look to the rest of the questions?
Yeah. I'm looking at D now.
Yeah.
Public health as a science or robust science-based should be at the top rank in any health policy of any country, at the same level as rule of law and defense. Technical limitations and challenges inherent of sciences themselves to keep them usable and up to date, organizational limitations and challenges, political, ideological, social contentiousness and its implications, a minimum consensus seems desirable, how minimum should be to be practical, and what are its practical limitations and challenges. We have covered much of that from the previous point. I do believe in the importance of public health in shaping policy. And I do think that it needs to be given priority. I think it should be a top consideration for countries who respect their citizens. But it's likely that for most public health problems, you will get better results if you try to enable your citizens rather than force your citizens to submission. So, you know, having reliable information, communicating reliable information, also information about interventions that you want to enable your citizens to use these interventions. I think that this is the best situation. There are a few conditions where I believe that probably you can take like a legal stance and say that, well, it's not just an issue of free choice. It's something that is tremendously harmful. And it's not just an issue of allowing you to be free to decide. I need to do my best to minimize the chances that you're exposed. I think coronavirus is not one such, because the risk to the vast majority of people is completely negligible. There are some people who have devastating risk, of course. Professional manifesto, signature lists, and such like, as the BMJ piece, I think we have covered that already. So I believe that for scientific matters, we should avoid trying to decide what science is correct and what science is wrong based on vote counting and how many signatures someone can collect, or how good an activist that person is. Signature lists are wonderful for ethical purposes. In the case of COVID-19, I have seen amazing scientists who are willing to sign such letters. I don't want to blame them, but I don't think that we should decide on what is true or what is false based on how many signatures were added to a specific statement. Next question is about modeling, its limitations, its debates, observed confusions, and almost unavoidable misunderstandings, for example, with Nassim Taleb. I think that, as I mentioned at the very beginning, lots of the decisions about COVID-19 were based on modeling studies, and their track record has not been very good. Their track record actually was not very good even in the past, even before COVID-19, but somehow the implications were not so serious. You know, most people would not really realize that models were so wrong, because the consequences of the modeling would not affect their lives. They would not affect them, their choices, their options. In the current situation, modeling has changed their lives in major ways. And I think that the failures of modeling have become very obvious, and their consequences can be really devastating. We know that modeling is one useful contributor to our understanding of evidence. So I'm not saying to completely discredit it. I think that we can work towards making it more transparent, more feasible to understand how it works, so that other people can test and reproduce its machinery. Many models are black boxes that people cannot even see how they work and why they get the inferences that they get. Giving enough room for the uncertainty that is involved in the assumptions, in the data that are fed into the model, and therefore also in the output of the models. I think many people, leaders, politicians, policymakers, but also scientists in this pandemic showed that they had no clue how unreliable modeling is. They just took these numbers at face value. They looked at the plots. They had very nice colors, and they looked very scary. And they just said, well, this is science. No, this is not science. This is one weak form of science, among the weakest probably that we have. And I think that this was not realized. This led to a lot of confusion. It led to very wrong expectations. It led to wrong decisions. For example, when people were thinking that they would get 10 times more patients coming to the hospital. They sent already infected COVID-19 patients from the hospitals to nursing homes, and then they devastated the nursing homes. So wrong models in COVID-19 was not just another failure of modeling. This has been a very long track record of mostly failures. It was something that led to people dying. And I think this is really horrible. And we should find ways to avoid it. Unfortunately, major institutions, universities, major journals, they still trust a lot of modeling that is very unreliable. They publish lots of it, probably with very sketchy peer review among other modelers who are just willing to promote and self-promote this type of work. I think it's becoming kind of a mafia. And I'm not saying this to, I'm saying it more in a laughing way rather than in a derogatory way. But I think these major journals and institutions should realize that modelers are not what they seem to be. I think the debate with Nassim Taleb was interesting, and I think it's worthwhile reading both my paper with Sally Cripps and with Martin Tanner, and also Nassim Taleb's paper for a comparison of views. I'm very glad that the debate happened because Nassim has a very powerful social media presence. I have no social media presence because I believe that it's not good to make a fool of yourself. And I think that, at least for me, I would be making a fool of myself very frequently if I were to use social media and just fire away at everything that comes my way. When we originally started the debate, the original position from the International Journal of Forecasting was that I would take the stance that forecasting for COVID-19 has failed, and Nassim would take the opposite stance. The way the debate evolved, Nassim took the stance that, of course, forecasting has failed, but it just has no chance to not fail. We just need to take for granted that the worst possible scenario will be the one to expect, and then just work around that most unfavorable, most pessimistic scenario and be prepared for it. I do have concerns about it, and I explained that in the paper along with Sally and Martin, because there's no such thing as a worst scenario. You have scenarios that have 1 in 100, 1 in 1,000, 1 in 10,000, 1 in a million, 1 in 1 quadrillion chance of happening. So what are you going to be prepared for? Where exactly are you going to set your expectations? And being prepared means that you do things that could have a lot of harm. So if you prepare for something that has a 1 in a trillion chance of happening, and you certainly destroy lives and kill people by doing it, that's really not good science. That's not good public health. So you need to have some good balancing of what are the benefits and what are the harms of different perspectives. You can use modeling cautiously, acknowledging its limitations, and trying to make it help you rather than dictate to you what you should do. But just a unilateral perspective of just do the maximum, ignoring all the harms that you cause, I don't think it's a good recipe. Last point is personal responsibility of leading professionals in public health at normal times and in crisis times. I think that there's personal responsibility for everyone. I think that personal responsibility is a feature of human life. And when it comes to professionals in public health, of course, it takes an extra dimension, because there's a sense that they can make a difference especially in crisis times, but even in normal times. I think we need to see this with some temperance, however, and avoid becoming advocates that forget about evidence and they're just out there to save the world. I think it's wonderful to save lives, to save the world, but the path to error is usually led by good intentions. And I worry that many people in public health are very weak in research methodology. They're very not well prepared in terms of understanding evidence, and especially the limitations of evidence. Many of them have very strong beliefs, and this means that often they go into war without really knowing what they're doing. So some matching of evidence and responsibility along with good intentions is really what we want. And finding the optimal point that would combine these features is not necessarily very easy. What we have seen in COVID-19 is also that many people who were not even involved in public health took the role of public health professionals. We saw the major newspapers and media really flooded with people who had no clue about public health, let alone evidence and research methods, who really took up to themselves to save the world. And this is really scary. We saw also lots of scientists who either have no training in public health and methods, or have some, but it's very incomplete and very unilateral. They also took very maximalistic positions. I think this is, again, very scary because in cases of crisis, you need to have complementarity. You need to have multiple people from different ways of life with different expertise, with very strong methods training that would try to give a very balanced perspective. And of course, act. I'm not saying not to act, but act in a responsible way that would maximize the ratio of benefit to harm. I don't think that this has happened, unfortunately, in the COVID-19 crisis. There's still time to fix that, I hope.
John, do you have time for the last one?
Yes. So, issue of auctoritas versus potestas in health and medicine generally. That is indeed too big theme to be out of place in this context, but nevertheless could be connected with the following approach. We have learned a lot about the difficulties in promoting ABM and relevant quality research and its diffusion. What we should learn from the COVID-19 pandemic or syndemic?
You have answered that with your former statement, as a matter of fact.
I think so. I think in the current pandemic or syndemic setting, it's even more difficult to do it, but it's even more important to do it.
Exactly.
Because we have seen that evidence-based medicine has been very difficult to promote. We have seen that it's very difficult to train researchers, physicians, practitioners in understanding research and understanding evidence and using evidence. So we had kind of a looming disaster all along. We had a disaster on our everyday medical practice, one patient at a time. Now we see it one population at a time or one globe at a time. And this is really scary. I mean, we've seen all these deficits of evidence, all this innumeracy, illiteracy, maximalizing beliefs, attacking science, attacking public health, attacking the population, and it's really scary. It's impossible to just get a bolus of evidence-based medicine overnight, but we need more before it's too late.